Hello, and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Jessica Adams. Joining me today is Dr. Stephane De Wit for a discussion on expanding access to long-acting ART in Europe. Dr. De Wit is a physician in infectious diseases at St. Pierre University Hospital in Brussels, Belgium. Dr. De Wit has experience working with patients from sub-Saharan Africa and Latin America that he will draw on to discuss the importance of expanding access to long-acting antiretroviral therapy for migrant populations in Europe. We'll discuss some of the challenges of accessing these patient populations, and he'll offer some thoughts on improving long-acting ART in the future. For the full online educational program, please visit the link in the show notes for this episode. So, Dr. De Wit, let's get started. What do you see as the main benefit for offering long-acting therapy specifically to migrant population?
I think that the main benefit would be to alleviate the weight of the disease on their shoulder and not, as Helmut mentioned, not getting reminded every day of their treatment. That's certainly for all patients, migrant or not. For the migrant, and certainly in the African community, management of hiding the disease would certainly also be a major advantage of this strategy. So for that population, I think the stigma is really a concern, and injectables could certainly be a very elegant solution to that and help these patients not to be always under pressure because of fear of being noticed as taking medication and blah, 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 blah. I think that talking about specific population who have been poorly represented till now is important. I think till now, most of the patients who have been included in clinical trials and in the real life are probably MSM, well suppressed, well controlled, etc. But going to other population and maybe more difficult population is now the next challenge. And certainly in an epidemic like the one we have in Belgium, which, as I mentioned, is around 50-50 MSM European guys and migrants mainly from Sub-Saharan Africa or Sub-Saharan Africa or Latin America, we have also a lot. And so this patient could be extremely interested in that strategy because of the fear of stigma or because of regular travels, etc., because they have to hide their disease, they are unstable, living places in Belgium, they have to move, etc., etc. So moving with pills, etc., could be, and taking pills once a day or more could be difficult. So this population is certainly a population which should be targeted and probably more advertised because this population has less access to information. They are less involved in patient associations and communities and so on. So I would certainly be interested in developing some programs to make that population more aware, knowing that it's a difficult population. It's a population in which the rate of loss to follow-up may be higher because of these different reasons. But nevertheless, that's for me a very important population. And that's why also we will now start in Belgium a protocol aiming to understand what this strategy could bring specifically to that population.
And how do you see that working? Do you have a system in place between the different clinics in Belgium where would it be possible for them to get an injection at one clinic and then if they move to pick that up at another clinic or pharmacy? What is the process and how do you see that working?
Yeah, in Belgium, it's the process is very clear. We have 12 HIV reference centers who cover probably 85% of all HIV patients in the country and who work in a common network with a group of administrators who looks at that. So that would not be an issue to have patients who move from one center to another. The channel of communication are very easy. The distance are very short. Belgium is not a big country. So, and secondly, as I mentioned, the medications are only available in those 12 clinics. That's it. Not in other hospitals, not in pharmacies, just in these 12 HIV reference centers. My concern would be more for patients traveling outside Belgium, getting back to Africa or Latin America, and then lost to follow-up. So that would be an issue. Certainly, it was an issue during COVID because of all the confinements, etc. But we hope not to know that again. But nevertheless, that's a population who would certainly be interested and should be more involved and advertised.
Great. And what systems do you have in place that could help with, if people miss appointments, getting them back into care, making sure that they have oral therapy to get by in between if they need to, things like that?
Yeah, that's a difficult issue. We have a system in place to get back to the patient who have been lost to follow-up, any patient, so the patient in general. So we have now an IT system which provides a warning when a patient does not come up for a certain period of time, and we can call them. We did put that in place more specifically now for the injectable, so the nurses take contact with the patient. As I mentioned, in a difficult population, sometimes getting back in contact may be difficult because you have no contact. They have no emails, they have no address, they have no phone. So that's why we should also be careful and not to launch this kind of strategy without knowing exactly how we will manage it and how we will manage the loss of follow-up of this patient. Because a patient on oral medication, okay, goes back to the pharmacy and we get a prescription, but this here needs a visit to the hospital. So it's different. So just to put everything in place before you launch this kind of program. That's my message. Yeah.
Okay. And do you see this only for people who are virologically suppressed switching to this, or do you think this could be an option for people who are not suppressed?
Well, it depends. It depends on the profile of the patient, and certainly at this time, if we had to make the scope broader, I would go only to patients with low-level viremia, not those patients coming back with 250,000 copies. That would not be the right. But as I mentioned, also we should be careful in terms of treatment history, previous treatment failure, and resistance. So I've heard from our German colleagues that they do DNA viral resistance. Well, this is not available everywhere. That's the least we can say. So I would be very careful to propose that as a strategy. And secondly, this is not the optimal. It's not the Graal. You can miss resistance also on the DNA. So I think getting back to the patient chart, looking to the treatment history, looking to the potential episode of treatment failure, and looking at the cumulative resistance testing, so addition of all the sequencing which have been made during the treatment, the patient history, that's very important to do. If you do that correctly, then probably patient with low-level viremia, where adherence is the reason for this low-level viremia, this patient could benefit from this from injectables. But I would go step by step, and I would certainly first go for trials in that kind of population and not open that in a real life, because we could go to some issues and problems.
Great. And how do you see future long-acting options being even more of a benefit to this population?
Well, certainly new regimens with less injections would be a major progress, of course, every 6 months. I have patients now who tell me every 2 months for me is too heavy, but I would be very happy to come back every 6 months. So those patients wait. So it's really a question of patient decision. Now, the other ways to move forward are not injection, but devices. So I think that the future devices could also provide a very elegant solution to these patients. And I'm sure that medicine will more and more go to this kind of devices, not only in HIV, but also in other chronic diseases. Let's think about, of course, diabetes, but also others. So yeah, the future is, I would not say the future is bright, but we will certainly be able to offer to many patients new ways of treatment. And the next step for HIV would certainly be the 6 months regimen. I think it's we have also to think about infrastructure, as we mentioned, and the clinical infrastructure. If these treatment become more and more used, maybe we have to go outside of the hospital and go and also get some help from the pharmacies, the GPs, and things like that. So not too quickly. I think we should go step by step, but certainly in the future, we will not be able to centralize everything in clinics. We will have to find new systems to allow patients to go to their pharmacy. Now in Belgium, pharmacies do the vaccine injections. Why not this one? Not tomorrow, but let's think about the next 5 to 10 years. Yeah, and be imaginative in the way we manage that.
Thank you very much, Dr. De Wit, and thank you to our listeners for joining in. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.